Well, good morning, everybody, and welcome back to the second session of the HRB's Grant Holders Conference for 2021. Now, this morning, we're going to be drawing on some learnings from the COVID-19 pandemic. And in particular, we're going to be looking at the ways that researchers can future-proof their research projects and their grants, to, I suppose, in case of unanticipated challenges or events. I think one unanticipated challenge or event in a lifetime is enough for most of us, but we need to be prepared. So before we get on to all of that, again, I'm just going to remind you of some of the housekeeping messages. Again, in case you have any problems, there's live support available in the right-hand side of your screen. There's also a speech-to-text function available as well through the mobile app, or again on your screen as well. And there's also a live Q&A available, and we'd really like you to take advantage of that and to put in your questions throughout the talks this morning. That's on the right-hand side of your screen as well. We'll try and answer as many of those as we can then later on in the Q&A panel session. Now, based on feedback from yesterday, because the HRB is a learning organisation, we would ask you, please, when you are putting in your question, ideally, if you could say, if you're directing it at a particular person, perhaps you could just put that in, just make it easier for the moderator. And also, if you could try and keep your questions nice and short, as short as possible. Think like a tweet, if possible, and that just also makes it easier. We'll get through more of them that way, which would be good. Okay, and of course, last of all, don't forget again to visit the exhibition area where you can see information on some of our projects. Okay, so let's move on to the first thing we have on our program this morning, and it's a really nice item. And what we are going to do now is we are going to announce the winner of the HRB's Impact Award for 2021. And before we do that, I just want to tell you what this is in case you're not familiar with it. The Impact Award was established by the HRB because we wanted to find a way to recognise a health or a social care researcher who has successfully translated their research findings so that they make a really big impact, incredible impact on people's health or on patient care or on policy or practice. And the aim of the award is really to highlight the importance of bridging that gap between the research and the generation of research through research and actually implementing changes for patients and for care. So it's conferred once every 2 years, so we don't give this out every year, so it is very special. And this is the second year that we have made this award. And the way it works is that people themselves are nominated by the head of a college, the head of school or research institute, or by the VP or head of research and development. And then we hand over those nominations to a judging panel. And I just want to say this year we had a brilliant response to this. And the panel came back and told us that actually they could have made a number of the applicants winners. So, and they were really, really keen to say that. It's not a cliche, it was true, and they really wanted many of the people who were nominated to to put themselves forward again or to be nominated again. So it was important to say that. Okay, our 2021 winner, just to say a little bit about them, has established themselves as a leader in respiratory medicine. Their research specializes in a genetic disorder known as, genetic disorder known as alpha-1 antitrypsin deficiency, and that leads to an increased risk of developing lung diseases such as COPD. This is a HRB-funded researcher, of course, and they have developed diagnostic and screening tools for this deficiency, which are now replicated globally, and have played a major role in the development of the only specific treatment currently available. The work has informed local, national, and international guidelines, so it's been really influential. Their nomination outlined how they set up a national targeted detection program, and that's the first of its kind in the world, which has tested over 20,000 people to date, and it was central to establishing the Alpha-1 Foundation of Ireland. One of the first acts of that organisation was to work with the Minister for Health in introducing the workplace smoking ban, and as we all know, Ireland led the way, was a leader internationally in that space. This researcher has enhanced the impact of the research, what's more, by actively supporting public and patient involvement and engagement, and works to educate the wider public on the dangers of smoking and vaping. So if you haven't guessed it already, we are delighted to announce the winner of the HRB Impact 2021 award, and it's Professor Jerry McElvaney, Professor of Medicine at RCSI, the RCSI University of Medicine and Health Sciences. And I'm hoping now that Jerry is going to join me on screen. And congratulations on your award, Jerry. I don't know if you are, if you're there, or if you are indeed.
Thank you very much, Mairead. It's a great honour for me to receive this award, and a great honour for my institution as well. I've worked quite closely at the HRB since coming back to Ireland over 20 years ago, and it's been a long and very, very fruitful collaboration. So again, I'm very, very grateful, and thank you very much for the award.
It's fantastic. Under normal circumstances, we'd be doing this somewhere nice in the evening, maybe, and we'd have a glass of wine and we'd be able to toast you or something. But unfortunately, we can't do that for you this time. But hopefully, somebody will give you a celebratory pastry or something with your coffee break later on.
Yeah.
Fantastic. Now, I know you very kindly prepared a short little overview or a presentation for everybody on your work. So perhaps now we can take a look at that. And congratulations. Oh, fantastic. I forgot to ask you to hold that up. That was very remiss of me. Congratulations anyway on your award.
Thank you.
Thanks, Jerry. So let's watch that now.
Hello, my name is Jerry McElvaney. I'm a Professor of Medicine in RCSI, and it's a great pleasure for me to accept the Health Research Board Impact Award for 2021. My research career began really in UCD as a student in the Mater Hospital from 1976 to 1982. And I graduated from UCD in 1982. I then did my general internal medicine training in Dublin. I realised, however, that to do specialist training, I had to go abroad, and I went from Dublin to Vancouver in 1986 and did a pulmonary fellowship there. I really enjoyed my time in Vancouver, but the pulmonary fellowship at that time put a lot of emphasis on physiology, and I thought that the future of research in pulmonary medicine really would centre on cell and molecular biology. And because of that, I went to work in the United States in the National Institutes of Health in Bethesda, Maryland. And there I started to work on inflammatory lung diseases, in particular on genetic inflammatory diseases, such as cystic fibrosis and alpha-1 antitrypsin deficiency. We realized at that time that although these conditions were relatively rare, they served as very useful paradigms for more common conditions. So for alpha-1 antitrypsin deficiency emphysema, we could extrapolate to more common non-hereditary emphysema, and the same for cystic fibrosis to more common forms of inflamed airways. So I worked in NIH and then in Cornell for a number of years and came back to Ireland in 1997. And I was appointed Professor of Medicine in RCSI in 1997. And since that time, I've been working here in Beaumont Hospital and particularly in the Smurfit building, doing research in inflammatory lung diseases, particularly those with a genetic component. So I'll talk to you about my work in alpha-1 antitrypsin deficiency. So alpha-1 antitrypsin deficiency is an excellent example of translational medicine. So what happened here was in 1962, two doctors, Laurel and Erickson, noted that on serum protein electrophoresis, some patients had a missing alpha-1 band. And they went back to those patients and found that 3 of the 5 patients had very severe lung abnormalities, specifically emphysema, even though they did not smoke. And they found that this protein was a serine protease inhibitor. And although they called it alpha-1 antitrypsin, they discovered, or other people discovered, that the main target of this protein was neutrophil elastase. It inhibited neutrophil elastase in the lung. And this gave us the protease, antiprotease theory of emphysema. So basically, what they were saying was, if you had a deficiency of alpha-1 antitrypsin in the lung, the neutrophil elastase had an unopposed proteolytic action. And that in cigarette smokers, even those without an actual deficiency of alpha-1, cigarette smoke would oxidize the alpha-1 antitrypsin in the lung, rendering it functionally inactive, again leading to a protease action in the lung, unopposed protease action in the lung. For many years, myself and others worked on trying to understand the pathogenesis of emphysema in alpha-1 antitrypsin deficiency and extrapolate from that to common emphysema. And we developed a therapy for alpha-1 antitrypsin deficiency lung disease, whereby we helped purify alpha-1 from the blood of so-called healthy or MM individuals, and we infused it into the veins of people with alpha-1 antitrypsin deficiency. And we showed that you could increase the levels of alpha-1 antitrypsin in blood and also in lung. And this alpha-1 was active against neutrophil elastase. And that was the first real COPD specific therapy developed in the last 50 to 100 years. Following that, I came home in 1987. And there are a few things that struck me. Alpha-1 was under-recognized and misdiagnosed, not just in Ireland, but throughout the world. The US studies showed that it could take 5 doctors up to 7 years to make a diagnosis. Now, we realized that environmental risk factors for alpha-1, for COPD, are well known, but alpha-1 antitrypsin deficiency is the only known genetic risk factor for COPD. And we thought it was really important to get a grip on that in this country. For example, in a paper in 1993, which suggested that around 250 Irish citizens had severe alpha-1 antitrypsin deficiency, we thought this was a significant undercalculation. So the first thing we did was we got access to the biobank DNA collection at Trinity College. This is a tremendous resource. So you have an anonymized database, collects data on age, gender, educational status, and county of birth for 1,100 individuals from mouth swabs. And we looked for Z and S variants of the alpha-1 antitrypsin gene. And we were surprised because there's far more alpha-1 antitrypsin deficiency than we would have thought. We found that 1 in 25 Irish people carry a Z gene. And that was a really major change in our way of thinking. And we looked at it further. We looked at the prevalence of alpha-1 antitrypsin on the island of Ireland. We found that there's approximately 3,000 Z individuals with a carrier rate of 1 in 25, an estimated 12,000 SCs, and over 250,000 MZs. So the number of ZZ individuals, severe deficiency of alpha-1 in Ireland, was 8 times more numerous than previously thought. We then decided we would make this condition more well known. We set up an alpha-1 foundation in Ireland. We set up a website, set up a Facebook page, and following that we also produced a lot of information guides and leaflets for patients and healthcare professionals. We were greatly helped by our colleagues in the US Alpha-1 Foundation, who helped us in our initial startup. And we also set up a targeted detection program. So the targeted detection program was interesting. Following a series of meetings in the World Health Organization and following some statements by the ATS and the ERS, it was determined that we should consider doing targeted detection for alpha-1 antitrypsin deficiency. And we were the first country in the world to have a national alpha-1 antitrypsin deficiency targeted detection program. This was financed by the HSE, and we tested all COPD patients, all non-responsive asthmatics, all people with cryptogenic cirrhosis, all first-degree relatives of patients or carriers with alpha-1 antitrypsin deficiency. And this is all done free of charge, and anyone who was found to have a deficiency allele was then offered a chance to come to our clinics in Beaumont Hospital. The roots of COPD are in your family tree, no doubt whatsoever about that. Now we started to build up not only awareness, but a large patient population to see if we could better understand alpha-1 antitrypsin deficiency, not just in the Irish context, but throughout the world. So we screened over 20,000 patients to date. At least 30% possess at least one abnormal alpha-1 gene. We've discovered nearly 400 ZZs and a similar number of SC individuals and over 3,700 MZ individuals. This is one of the largest alpha-1 clinics in the world. And we've done studies to help our patients. So we were the lead center in the RAPID study, in which ZZ individuals were given plasma purified alpha-1 antitrypsin once weekly or placebo over a 2-year period. and we found that intravenous alpha-1 antitrypsin therapy led to a 33% reduction in lung density, as measured by CT scan over a 2-year period. And then at the end of the 2 years, those in placebo were switched to medication, to alpha-1 antitrypsin medication, and again was a decreased decline in lung tissue density. This is the first time ever that a medication was shown to impact positively on progression of emphysema. It was a breakthrough, but you'll notice that it didn't completely stop the loss of lung tissue in these patients. We've learned a lot over the last number of years, usually with the help of our patient populations. So we know now that alpha-1 antitrypsin deficiency is common. 1 in 25 people carry a Z gene. We know from our research that people with the ZZ form of alpha-1 get emphysema even if they don't smoke. We know that MZs, now remember there are 250,000 MZs in Ireland, have a 10-fold increased risk for COPD if they smoke. We know that SCs have an increased risk for COPD if they smoke. But interestingly, MZs and SCs have no increased risk if they don't smoke. This has led us to really concentrate greatly on smoking cessation in this population. And perhaps one of the more important things we've discovered is that alpha-1 antitrypsin deficiency is not just a protease-antiprotease imbalance, it's an inflammatory disorder. Alpha-1 has a myriad of anti-inflammatory effects. You can see in the graph on the right. It's a massively important anti-inflammatory, and when you lack alpha-1 or the alpha-1 antitrypsin is inactivated, you're prone to inflammatory lung disease. There are big unanswered questions in this area. Is alpha-1 antitrypsin deficiency emphysema the same as common emphysema? Is the COPD seen in smoking MZs and SCs the same as that smoking in people without alpha-1 antitrypsin deficiency? How much alpha-1 do you need to protect your lungs, your body? We have big lessons here from COVID. We know that in COVID infection, the normal response is to really massively increase the amount of alpha-1 antitrypsin in the blood and in the lungs to protect those organs. And we need to understand better the pathways of emphysema to see what new therapies we can discover or what old therapies we can improve. So we plan to evaluate our patient population very effectively over the next number of years. We will look at ever smoking and never smoking ZZ, MZ, SC, and MN individuals. We will use state-of-the-art CT scan evaluations, pulmonary function evaluations. We measure quality of life, activity, and we look at inflammatory biomarkers, which we have developed in our own lab. We will evaluate bronchoalveolar vase and lung cells. We look at what controls secretion of alpha-1 antitrypsin in response to inflammation or infection. And we have a great opportunity to compare our results to other large databases, such as the European alpha-1 registry and the NIH alpha-1 antitrypsin deficiency biomarkers consortium. We think that by performing effective research in these populations, we will make great inroads into understanding not only alpha-1 antitrypsin deficiency emphysema, but non-hereditary emphysema. We'll improve the therapeutic options available to us, and we'll make a real impact in patients' lives. These are the people that helped me in that task. I'd like to end there by thanking you all very much for your participation. And again, I'd like to thank the HRB for giving me that award, which I think will help us greatly in performing what we need to do in this area.
Thanks very much, Jerry. That was a fantastic example of how the whole, I suppose, spectrum of health research comes together to make a difference. You know, you've got your basic research, your discovery research, clinical research, population health, all coming together, and it made a real difference to people's lives. So congratulations again to Professor Jerry McAvaney, and indeed the team and everybody who's worked with him, because I know these things are a team effort. Okay. Let's move on now to our first talk this morning, our keynote talk, and I am delighted to introduce our speaker, Professor Martin McKee. Just a little bit about Martin. He is qualified in Belfast, in medicine in Belfast, and then he subsequently trained in internal medicine and public health. He's currently the Professor of European Public Health, and he's the medical director at the London School of Hygiene and Tropical Medicine. He's the research director at the European Observatory on Health Systems and Policies, and he's past president of the European Public Health Association. He has numerous publications to his name. He's also a member of the UK Academy of Medical Sciences, European Academy, and the US National Academy of Medicine, and very relevant at the moment, and very interesting to hear his perspective. He's a member of the UK's Independent SAGE Committee, and he's received several awards for advocacy. Now, Martin has a really intriguing title for his talk, and given his vast experience in health research and indeed his reputation for speaking truth to power, I think we're going to be in for some candid insights into how not to lose sight of the importance of health research, despite the challenges that are presented by a pandemic. So here is Professor Martin McKee on a Journal of the Plague Year.
Thanks for asking me to give this talk today. I have to say that once I'd agreed to do it, I immediately regretted my decision because it's really not an easy subject to address. There are so many things that have changed this year, and I don't think we yet have the answers to all of the problems that we've confronted. But what I've tried to do is to look at some of the issues that we've grappled with and had to reflect on over the year. And I hope that what I'm covering will be of some use, at least in terms of stimulating some debate about how we go forward. Just a reminder, the reality of it is that for many of us, much of the field work that we do became impossible. Now, of course, not all researchers do primary data collection. Many are analysing data from existing surveys or doing systematic reviews, but we do quite a lot of work on the ground. And in my case, with creating major challenges, we were doing work in countries like Malaysia, the Philippines, sub-Saharan Africa, where we simply could not do the work that we had scheduled. The other thing was that there's been no possibility to attend project meetings or conferences in person. And that poses certain challenges because, of course, we've been able to use Zoom and Teams and WebEx and WhatsApp and all sorts of other media, but they're not quite the same. Again, something I'll reflect on in a minute. Researchers have had to balance work and domestic responsibilities. Well, my children are now grown up. They're researchers in their own right, and so we haven't had to deal with young children running around the house. But for my younger colleagues who have had to, it's been very difficult. Then, of course, many of us have had to refocus our work on COVID-19 research and particularly on policy engagement. So we'll think about that too. There have been delays in existing projects, and crucially, policymakers who are looking to us for answers need them yesterday, not in 6 months' time. So what I'd like to cover are a couple of issues: fieldwork in a pandemic, mutual support within research teams, what I call the tyranny of Zoom, the question of dissemination, publish, perish, pre-publish, or tweet, redirecting research towards COVID, and then something about science policy and our responsibilities to engage with the public and with politicians. So let's start with some of the challenges of doing fieldwork during a pandemic. There are several implications of the pandemic. First, we've had to develop, design, implement at great speed new studies which address aspects of the pandemic, aspects of the transmission of COVID, aspects of the response, and so on. And secondly, even when we've done that, we've had to change them often at short notice because of the situation changing, lockdowns, the release of lockdowns, and so on. And of course, COVID has had huge implications for studies that have nothing to do with it. We've had to look at changes in procedures, how we conduct interviews, for example. It's had an impact on timelines. It's had an effect on budgets and grant periods. And of course, we've been having to wrestle with funders, some of whom have been more sympathetic than others. Now, of course, I could write an entire book or give an entire lecture on the challenges of doing fieldwork during a pandemic, but I'm going to limit myself and perhaps look primarily at some of the ethical challenges that are arising. Because, of course, the IRBs, the ethics committees that we report to, are requiring us to adhere to the same principles as we would do at normal times. We need to get informed consent to ensure privacy and confidentiality, data security. We need to work out what to do if we need to refer people for treatment, for example, as a result of something we discover. We have to ask ourselves, is this really the right time to do research? Because particularly if we're looking at the responses of people working in organizations, much organizational research, the situation has changed entirely, and anything we find might not be generalizable to more normal times. And we need to think whether remote data collection is going to become the new norm. So what changes do we need to make if we are to get informed consent for research from the participants? The first thing is that if we've got work that's already in progress at the beginning of the pandemic, we may need to change the consent sheets, the patient information sheets. They may need to be then distributed in a different way. We need to tailor them to the new ways of data collection. And of course, the challenge is that we have to go back to the ethics committees, and we hope that they will respond more quickly than they usually do, recognizing the urgency of the situation, but we shouldn't underestimate the time available. It's important to note that consent can be written even if people are not actually holding a pen. There are other ways of writing in this day and age, for example, in an electronic signature or a text confirmation, but of course those do require that people do have access to the appropriate types of equipment. And consent can be verbal, and this is perfectly reasonable with audio recording or perhaps written check sheet records. So the problems are there, but they're not insurmountable. But what we do need is that ethics committees understand the challenges that we face and are able to be flexible and to respond quickly. And I want to talk a little bit about mutual support within research teams. Okay, you can see my background in the picture here. Many people have seen it on media appearances across the world. I'm really lucky. I've got a fantastic study in my house. I've got all the facilities I need. I've got fast broadband. I've got laptops. I've got good communications, and that's great. But not everybody has. And we need to remember, particularly for early career researchers, that they may be living in a one-bedroom flat, they may be in a home with multiple occupancy, they may have children running around that they got to look after. They're juggling with homeschooling at the same time as trying to do their work. And I think it's really important for those of us who are in a more privileged situation to reach out and to make sure that we support people. Certainly, I, and I'm sure many other people in my position, have been doing much more work on mentoring early career researchers, in my case, in many different countries, and trying to listen and understand the challenges that people face. So I would just encourage you, if you are somebody of my generation, really to reach out and make sure you do that. And just try to get yourself into the shoes of those who are struggling at a time like this, because it really isn't easy. Let's talk about the tyranny of Zoom. Many of us are spending hours every day. I can have days when I'm spending 8 to 10 hours on Zoom. So what do we do to try to minimize the challenges that this poses? So I've been reading around a little bit for advice from others, and what do they say? Well, one paper talked about learning to overcome the presence of absence, which they describe as a deep state of heaviness and separation on Zoom, because we are together virtually, but we're separated physically. You don't have those opportunities to raise your eyebrows when you're looking at somebody, or a non-verbal communication in quite so many ways that you would have round a table. You might look down and shuffle your papers in a very visible way. We communicate in many other ways just than simply talking to one another. And also, it's very easy to switch off. You can switch off your camera, of course. There are people who thought they switched off their camera when they were doing other things. I won't go into it. I'm sure you've heard the stories. So be careful that you really have. But also it's really important that we try to engage with everybody and make sure people are not feeling left out. Remember, again, particularly some more inexperienced and perhaps insecure of our colleagues may feel it rather difficult to break into established hierarchies, and we have a responsibility to encourage that. I like this one. In this particular article, there was a lot of other advice I'm not using here about Zoom makeup and so on. Clearly, it doesn't apply to me with a face for radio. But this advice also said that staring at your face for hours on end is probably affecting your mental well-being. Yes, I can echo that. So it advised us to focus on our best bits if we can find them. But more practically, avoiding multitasking. We all do it. We're on a conference call, but we're not really engaged. We're putting in references into it. No, that's my guilty secret. We're editing documents. We're doing all sorts of other things. Build in breaks. There should never be 1 hour Zoom meetings. They should be 50-minute meetings, because then you've got 10 minutes to get a coffee and go to the bathroom in between. Try to reduce on-screen stimuli, and this is something I haven't done. You'll see hypocrisy here, but we're advised to encourage plain backgrounds. Try to make social events on Zoom opt-in, they advise. Now, a number of units, another number of departments do try to bring their team together to bring people together in social networks, but people can feel pressurized. Try to use phone calls or email from time to time, and don't do everything on Zoom. Publish, perish, pre-publish, or tweet. How do we disseminate in a time of a pandemic? Well, one of the things we have seen is that medical journals are reviewing papers faster, but that is almost entirely due to COVID papers being reviewed faster. Other papers are, if anything, being reviewed a little bit slower. And we also know that there has been an enormous upsurge in coronavirus research, as this graph of preprints and journal articles shows. And this is something that I confess I've been guilty of contributing to, and I guess many of you have been too. And the difficulty is separating out those that are worth reading from those that are not. We have had preprints because, of course, in the middle of a pandemic, when we need the evidence quickly, we simply cannot wait for the months that it can take to go through the review process and then eventually to get into print. So preprints are becoming increasingly popular. They're the way that people are communicating. And in many ways, this is good because we are getting good information. But unfortunately, we're also getting not so good information. And here are two of the more notorious studies that you may be familiar with. The Santa Clara study suggesting that a very high proportion of the population already had immunity to COVID, which was not the case, and a similar study that got a lot of media attention, not least because it was press released by an agency with links to politicians, which suggested that at a very early stage in the pandemic, we were already close to herd immunity, and therefore this and its authors in particular have been very much in the forefront of arguing for not having restrictions, and more recently for arguing that we maybe don't need vaccinations. So we have to be really careful with preprints. They've got many good points, but there are many problems too. Twitter actually is where I get an awful lot of my information. Now, we all know that there's a lot of nonsense on that. Fortunately, a lot less since Donald Trump and many of his supporters were taken off Twitter. And that's quite interesting in terms of my colleagues who have looked at the number of accounts that are supporting electronic cigarettes that disappeared in that clean out. But here are some of the few people that I follow that I find to be very helpful. But there are many others. Christina and Sarah Rasmussen, particularly good on schools, Susan on behavioral sciences, and Adam on modeling, and so on. So I think if you follow the right people, you really do get insights that you're going to miss otherwise. What about redirecting research during a pandemic? Well, here we were faced with the problem of a new infection, enormous knowledge gaps, even though there was huge progress made earlier, the very rapid sequencing of the genome, but people were dying and there was really no time to wait for a peer-reviewed publication. Time was of the essence. How were we going to generate evidence quickly? And crucially, how much evidence is enough to act? The recovery trial was one of the rare successes in the UK. We haven't done much very well. We got the vaccine rollout right, but we failed on testing and tracing. And we, of course, delayed our restrictions. And, that's why we have such high death rates and such a big hit to the economy. But this was good because it was an opportunity for almost every patient who was admitted to hospital to be invited to be part of a clinical trial. This is how we found out that chloroquine did not work. It's how we found that dexamethasone did work. And looking ahead, we really need to make sure that we have a system in place, the infrastructure there, so that in many countries, the protocols have been pre-approved. They'll need to be tailored a little bit to the particular cause of the pandemic. The ethics committee approvals are there in principle, even if they just need to be adapted a little bit and signed off. And everything is ready to go. We cannot have the delays that we have had in so many countries in trying to understand what the nature of this, what the best treatments were for this pandemic. But I think we can expand that into all sorts of other areas of the sort of questions we can anticipate will arise in a new pandemic, such as the nature of the spread of the particular microorganism and the measures that might be implemented to reduce that. Moving on from that, we have the question of how much evidence we need. And we've had heated debates all the way through, for example, about the role of masks or face coverings. And I think this has highlighted a real schism in the health research community. There are those who will argue that the absence of evidence should mean that something should not be implemented, and particularly the absence of evidence from a clinical trial. Yet here we are in an emergency when we need to do something. So what do we do? Face coverings were a particularly interesting example because once you realize that their role was to, as a form of source control, to prevent individuals infecting other people, so where the intervention was applied to one individual and the outcome was measured in other individuals who would not have an opportunity to consent or even may not be easy to identify, you can see the challenges that were involved. So holding out for clinical trial evidence certainly was not the way forward here. But there were lots of other ways of doing it. Natural experiments, as in Germany, taking insights from fluid engineers, aerosol engineers, and others. And I think everybody accepts that they are playing a very important role. But it took a long time for us to get there. Now we can come to science policy and ask, what are our responsibilities as scientists? Now, there are many people in many branches of science and in public health who argue that it is sufficient for us to put our data in the public domain. We should not, they argue, be getting involved in operational or policy matters. We should not be having a view on the decisions of politicians. And that is, I say, very strongly held. And certainly the work that I've been doing, I've been challenged for, why are we getting into operational issues? Why are we asking about the implementation of policies when we should simply be providing the evidence as to whether the policies might be considered by politicians? Well, we were concerned about the way that evidence was being generated and transmitted to politicians in the United Kingdom. There is the Scientific Advisory Group on Emergencies, but initially its membership was secret, its minutes were secret, its recommendations were secret, and ministers were able to say they were following the science, but we had no idea what the science was. So in response, a number of us created an alternative SAGE, an independent SAGE. And what we do is spend a lot of our time voluntarily, several hours every Thursday evening, and then a press briefing every Friday at lunchtime, writing papers, pulling together data, where we explicitly engage with the operational matters, where we explicitly engage with policy. Now, in fact, where we overlap with the official SAGE, we hardly ever disagree. I don't think we've ever disagreed fundamentally. But what we can do is go beyond what they do, and we can engage with the public and, more importantly, listen to the public, because what has become clear is that co-creation of knowledge, listening to people on the front line, is crucial on this, because otherwise the policy recommendations will simply be wrong. And of course, you have your own in Ireland, and I congratulate you on that. I think there have been some very valuable lessons coming out from that too. So thank you for that. I want to conclude with a few very brief words about conferences. Why do we go to conferences? Well, to disseminate our findings, to exchange ideas, develop hypotheses and share solutions, but also we go for networking, and particularly for early career researchers, and to build trust and cement trusted relationships. Organising major conferences is not easy, as Anthony Staines certainly knows. It typically involves 2 years in planning, a vast amount of work by volunteers. Again, I thank the work of our colleagues in Dublin for all of their work on the 2021 European Public Health Conference. The business model is based on break-even number of attendees, and if we don't have that, then you lose money, and that can be hugely problematic. We can look to a hybrid model which increases price, but if we do that, then we may lose sponsorship from many of the advertisers, others, and we have to ask if they're still viable. We can have online conference platforms, but they never work as well as we would like. Broadband speeds can exclude some participants. They can reduce spontaneity. They can reduce the possibility to engage with people post-presentation, a particular problem for early career researchers. We risk having a new form of digital exclusion. How do we find new ways to connect early career researchers with each other and with more senior researchers? We need new forms of networking. And I'd like to thank my colleague Sarah McQuinn for her work on Youth and Next in working very hard to bring people together. Well, I don't claim that this has been a comprehensive overview of doing research during a pandemic. It has been a bit random in terms of the issues that I've been discussing, but I think that they are relevant to all of us in our different ways. And I hope at least they're a basis for discussion. So thank you very much.
Martin, thank you very much indeed. That was actually a fantastic overview, and you covered so much. I think we can all relate to the tyranny of Zoom in particular. I think we've all had quite enough of it. So I very much appreciate your suggestion that we all, occasionally resort to the old-fashioned telephone. I don't know if you're coming back to, or if you're able to take any questions. Is that? But I just had a question for you, particularly around. There you go. Hi, Martin. Thanks.
Hi. Sorry. Yeah.
No problem at all. No problem at all. I just had a question for you, I suppose, around the whole policy, that link between policymakers and researchers, or the scientific community. Do you think that, is this going to lead to any lasting changes in the way we interact? This is something we talk about here all the time. Academic researchers think, well, how can we influence policy? And policymakers think, well, what are they doing over there? So that relationship. Do you think this will lead to any lasting changes in that relationship, or what are your thoughts on that?
I really don't know, but it's important to say that it varies enormously among countries. You had Lisa Marie on in the conference yesterday, and we have a situation in Finland where the government is incredibly open to a wide range of views, including from outside the country. So, I was on the panel that reviewed the recent proposals for reform in Finland. I'm on an advisory panel for the Belgian minister. And even in the past, I've chaired a review panel for the Chinese government, looking at the midterm evaluation of their reforms commissioned by the State Council. But in the United Kingdom, and I speak about here because I live here, it's just simply unimaginable that we would ever invite somebody from China to come in to review the NHS reforms. And so I think it really does vary a huge amount. Perhaps in smaller countries it's easier, but the United Kingdom is particularly difficult because you do have a Westminster bubble, and here in particular politicians get their input often from think tanks that have got a somewhat opaque funding, the Institute for Economic Affairs and others, which I think of all the countries I work in, and I work in a lot, is probably the most difficult to influence. In fact, it's even easier to have some input into Russia, for example. So it is particularly problematic. Whether it will change in the future, I'm not sure that it will here. I can't speak so much about Ireland because I don't have first-hand knowledge, although I am in Dublin from time to time talking to people in the Department of Health, and they are very open, in my experience, certainly to learning from elsewhere. But you will know that much better than I do.
And I mean, the whole question, I suppose, of scientific advice and, following the science. You mentioned this, I think, earlier in your talk, and of course it assumes that there is the science, and of course science changes, which probably, maybe that's news to some people, I don't know, but do you have the whole experience over there of skepticism, or people saying, oh, they're telling us this one day and something else the next day? And how do you think we should approach that as the scientific?
Yeah, well, we know, of course, that there are powerful vested interests that promote that narrative, and the tobacco industry has been doing it for years. So, there is this. I think it was Harry Truman who said that he needed more one-handed economists because they were all saying on the one hand this and the other hand that. But we have to be open about how the science does change. But on the other hand, we shouldn't overplay it. There are some things that are fairly fundamental that don't change. So there is a push, and you see that there was a document produced a few years ago we wrote about the Brussels Declaration, where the tobacco industry, the alcohol industry came together to create a statement which was really emphasizing this uncertainty. A report by the Brewers of Europe that said, well, you can't really say anything with science. A lovely quotation: violence is a nebulous concept. And then they argued that because we couldn't easily define violence, they said for epidemiological studies, all of the literature linking alcohol and violence should be discarded, to which our response was, I think someone who's just been slashed in the face by a broken bottle would recognize that as violence. Yeah, that does mean that you also do need to have politicians and policy advisors who are scientifically literate, and that is a problem. And again, forgive me if I keep talking about where I live. Otherwise, I am Irish, but I live here, and we have seen I'm not sure if we've got any scientists in the House of Commons at the minute. We've got a number of physicians, but they're becoming a vanishingly rare species, and that is problematic. So I think we need to work very hard on developing that receptiveness, because communication involves transmission and reception.
Mm-hmm. Okay, fantastic. So I think you're going to be staying with us, or at least coming back to us again for the panel later. So again, just a reminder to everybody, if you have any questions for Martin, just to put them into the live Q&A. So thanks again, Martin. Thanks very much indeed. That was really excellent. We're going to take a short break, and we will be back again just around 10 o'clock. Thanks very much, everybody. Well, welcome back, everybody. And just to say, there's lots of lovely messages coming in congratulating Jerry McElvany, which is great to see on his HRB Impact Award, and one there from Evan Mulroe from Cancer Trials Ireland, speculating that it must be Monaghan's year. So let's hope. Okay, we're now going to move on, and we're going to hear three presentations from different perspectives. I'm reminded of what Martin McKee said earlier there about, understanding where other people are coming from and the difficulties that people are facing. So we're going to hear from different perspectives here, from a funder, from the health services, and also from the perspective of trying to run a trial in the middle of a pandemic. So first up, I'm going to welcome back Teresa Maguire, my colleague Teresa from the HRB. And Teresa is going to talk to us about COVID-19 and reflections from the perspective of a national funder.
Good morning, everybody. Welcome back to those of you who were with us yesterday. And I'm delighted to be able to join in this session and to perhaps contribute to the panel discussion later on by contributing some reflections from a national funder's perspective. I think, like everybody else, the HRB was responding to what it found unveiling before. So we needed to be flexible, we needed to be responsive. I think, and I hope you will conclude by the end of it that we were, and we continue to be, and we need to be. What helped us? Well, I think it was helpful that we had a really good and close relationship with our funder in the department, who in this instance was also the key, certainly in the first instance, and still a key decision-making organisation, certainly in terms of the public health decisions and the work of NEFIT. So that relationship stood us in good stead. I think you need to work well and candidly and with agility with other funders, and I think those relationships were in a good place. As we touched on yesterday, there's generally good cooperation and collaboration between the national funders, so that stood us in good stead. I suppose 2 points I would make, not in contrast to that, but certainly was challenging, was that wanting to respond will only take you so far. But much of a funder's income is pre-committed on multi-annual grants ahead for many years and across many things. And that's a struggle for a funder that gets 1 year funding at a time and only knows from 1 year to the next what it's getting. So the reality was that it was largely the small amount of discretionary funding, as it were, that hadn't already been committed, and you were redirecting your funding, whereas really what would have been desirable would have been additional funding in middle of a year, in the middle of the crisis, and that didn't happen. You were looking really to the next year in terms of looking for any additional funding. So there is a residual opportunity cost to that, and that will linger for quite a few years to come. Having said that, I think you're all aware, many of you applied to our rapid response calls that went out almost within weeks of the crisis arising through the pre-call announcement and then the full call, using the WHO blueprint and the 3 strands as our kind of themes for that call. We co-funded the social countermeasures call with the Irish Research Council, which we were delighted about, funded 36 projects, over 5 million invested in those, and I think that relationship really will continue to go from strength to strength and make sense. And we were really pleased with that. We also funded other projects through other initiatives, like our Research Collaborative on Quality and Patient Safety, where 4 dedicated COVID projects were run. And we also supported through our Horizon contact and delegate role, you to be aware of and participate in European Horizon calls, and Irish candidates were successful in that. We also responded in a slightly different way, but a really important way, to provide for the recommendation that was in the ethical framework for decision making in a pandemic, that you ideally have a centralised research ethics committee to look at COVID-19 projects in an expedited fashion, and literally within weeks, I'd say about 1 or 2 day old new national office that was being established in the HRB mobilised, and Jenny and the team mobilised in there really, really quick to have a national coordinated response for research ethics, and an NREC for COVID established and functional within weeks, and have approved almost 100 applications for COVID-19 projects. Important to say that really, really good cooperation between entities like the HPRA in relation to streamlining the trials part of the application process, the HRCDC leaning in from the data aspects of it, and support from the Department of Health, and support from local research ethics committees, and most of all support from the research community, who unquestionably answered the call and agreed and accepted to participate on the NREC itself. So I think this was a real success, and I think a real proof of concept, if ever we needed one, that NRECs are definitely the way to go for multi-centre studies in Ireland. Our longitudinal studies really came into their own in the pandemic, with a real focus, and a badly needed focus, on vulnerable and populations disproportionately affected by the pandemic. These are powerful tools at the best of times for policy makings and to responding to things that happen around us, policy changes or otherwise. And just 2 examples here of the surveys of the older adults, community dwelling adults, and then older people with an intellectual disability in those surveys. And hopefully those surveys will be repeated again and will give us even more evidence. But really, really powerful and significant data and evidence coming through them, and again showing the value of longitudinal cohort studies in our research ecosystem. Another area that we worked very closely with the Department on was in relation to trials of COVID-19 treatments. The department made a decision at the outset that it wanted its public investment in large multinational adaptive trials of COVID-19 treatments to achieve the statistical power, and we worked very closely with them on that, largely because of our prior investment in CRFs and other trial supports, and the department were aware of that, and I think again that has been a real success. Through Ireland is involved in the MAP-CAP a trial in ICUs led by Alistair Nicholl, the WHO Solidarity trial led by Joe Eustace down in Cork and supported by CRCI, the prospective observational study Sprint Sari, again that Alistair has taken a lead on, with 17 sites participating in Ireland, and huge learning from all of those that I just don't have time to go into today, but really, really invaluable learning, and I think a great contribution from Ireland in this regard, and going from strength to strength with ECRIN now, and as a lot of developments in Europe happening, including the EU vaccine network trial, now seeing Irish involvement in that, and thinking how we go to the next level and continue the footprint that we have demonstrated so far in this pandemic. So again, really, really great work there. And just putting this up, I suppose, to again, for the conversation to go, scientific publishing is in a completely new place. It's completely reimagined. If you were to tell me that, a year or two ago, that over 64% of all publications are going to be in preprint ahead of peer review, I just wouldn't have believed you. And I think this is we're not going backwards. I don't think in this regard. But of course, that does throw up challenges in relation to what is the trade-off, if I can call it that, between acceleration, transparency, quality, and reproducibility. So I think lots of discussions ahead of us on this issue. I think undoubtedly, we knew this anyway, but COVID has just shown us the future is open. And just a reminder of, I suppose, the COVID collection that's on the HRB's open research publishing platform there, but definitely the future is open. I think this is an area that I just wanted to mention because I think Ireland just really punched really high up there and well above its weight in relation to evidence synthesis, feeding that into the national process, but also the whole work going on globally on optimising the use of existing and the rapidly evolving evidence and data, trial data, etc. that was coming through the systems. And again, this is another example of where when you've invested in networks, when you've invested in entities like Evidence Synthesis Ireland and Cochrane Ireland and TMRN for many years, there is a network, there is a resource, there is an ability to pivot, and that's exactly what this group did. They pooled their collective resources. They formed this entity called the Emergency Evidence Response Service, and they basically, not to put too fine a point on it, they churned out rapid reviews, evidence reviews, updated reviews that were being, importantly, were those that were being prioritised at the international level. They worked with lots of other similar evidence synthesis centres globally, like EPI, McMaster in Canada, and so on. And they linked in with the Cochrane Library Global in terms of their special collections, the rapid collections. They contributed a huge number of reviews to the World Health Organization update of the clinical management guidelines. They contributed to Evidence Aid. And they participated in this really, I think, very exciting initiative, and is really something that is a sort of a sign of things to come, COVID NMA, which is an open living mapping of and a living evidence synthesis to inform decision making. If you haven't gone into this website, you really should, and you should take a look at it. It proved invaluable, and is proving invaluable for decision making, linking into NEFID and into the department and so on, and used by HICWA to do kind of HTAs and assessments of trial evidence, and constantly supply that insight into the department. Used by the WHO. It's really used, by just so many decision makers, including, going back to those trials I mentioned earlier, the trial steering committees who are trying to figure out what the evidence is, what's emerging, staying abreast of that, what new treatment arms to introduce, etc. Like I said, this is really a sign of things to come, and it's daunting. It's weekly searches, it's weekly updates by hundreds of people all around the globe. So how do you coordinate that? How do you sustain that? How do we take this forward? And how do we as national funders try to contribute to that? And some really challenging but really exciting questions to think about into the future. But a fantastic resource, and delighted for Ireland to be such an integral part of this activity. Just wanted to include a slide on misinformation, conspiracy theories, and so on, following on from the theme of the HRB conference last year around, trust in research and transparency and so on, and that whole issue of fake news, misinformation, and so on. And we really see this during the COVID pandemic. And so this is an area that the HRB is really interested in building a research agenda and learning more about into the future. I think it builds very nicely on both our evidence synthesis investments on the one hand, and also our public and patient involvement, and our citizen engagement piece. And so I held facts, which was initiated out of Galway with the support of ESI and Cochrane and TMRN, and the HRB contributed in a small way to this, is really about enabling the public in a quick and an easy and an accessible way to ask questions. Also engage with that and start to understand and take ownership of how that evidence can inform their own decisions. So a very exciting initiative, and is definitely hitting on an area that I think we will all continue to talk about, and we need to think about interventions in this space, both nationally and globally. Just wanted to say a little bit about some current developments. So things really, I suppose, in the last number of months, not back as far as March and so on. They're often things that we've been talking about for a long time, but in reality, because of that issue around funding and not having additional funding for a large chunk of 2020 to be able to do these things. Pleased to say that through our discussions in terms of 2021 funding with the department, we have been able to initiate a process, at least, to get an application in to, and it's under review at present, so I'm not going to say very much about it, but to establish a national COVID-19 biobank. And that's important in its own right, and it's badly needed, and will make a huge difference. But there also, we would very much see it as the start of an investment in this space of underinvestment, and as we discussed yesterday in the innovation infrastructures section, absolutely key to a lot of the issues like omics, personalised medicine, cancer, etc., that was mentioned in there. So that's an exciting development currently. Hopefully next week, early stage of next week, all going well, fingers crossed, we will, with the CSO and the department, the HRB will be announcing and opening a process whereby researchers can seek access to patient level detail in the COVID-19 data portal for research purposes. And so lots more about that, and I'm not going to spend too much time because we spent a lot of time yesterday talking about secondary use of data, but a really exciting initiative for us. We're also in discussions with the Department of Health about establishing a structured PhD training programme for public health modelling, to build our medium-term capacity in this space where we can have maths and stats and geographers and epidemiologists and other healthcare professionals working together in this space. I think that was a need that was clearly identified throughout the process. And again, I won't say much about this because we talked about it yesterday, but we're again working with the department and the HSC and linking into a new initiative in Europe called Population Health Information Research Infrastructure, which is very much about how do you set yourself up for sharing population health data in this instance safely and securely for research and for decision making, for surveillance and for policy purposes in Europe. So again, lots of learning to come from that. Before I wrap up, I just can't not comment on the issue that is concerning all of you in terms of uncertainty and so on. That is the impact of COVID-19 on all of your research grants. And I think I'd like to think that the HB responded very well initially by putting up FAQs, by engaging with you on that. We know that is the case because we've already approved over 70 no-cost extensions and budget allocation requests for you. We will continue to do that. The annual reports process is out. We will be looking and seeing what we can do to support you in that regard. And of course, I'd encourage you to engage with the HEA fund, which has been made available by government for those projects that require supplemental funding where staff or students otherwise would be have to cease their activity. So we're engaging deeply in that process with HEA and others, and we'd encourage you to do so. We know that HRB researchers have been funded already, and we hope many more will. I've touched on many of these issues already. We've learned a lot about funding models for the future. It is international, it is collaborative, and we need to build flexibility somehow into our funding models. As a funder, we found ourselves asking questions, do you wait to see what emerges Or in time of the pandemic, do you need to be more directive as required? Do you take positions on things where there is an urgent need? And I think we probably did a little bit of both. And I think on the conversation yesterday about administrative burden, I think we can all learn, and we will certainly be thinking about what we can take from rapid response research calls to bring into our normal processes. COVID exposed and exacerbated existing flaws in our health research system. That ain't going to surprise anybody. Biobanking, access to data, public health capacity, those issues came to the fore and need to be rectified. And I've put a provocative question in here towards the end, which is, it wasn't always clear, or did we not have a government lead for research coordination? Very unsettling political times that this was happening in, but it wasn't clear. Was it the Department of Health? Was it the Department of Taoiseach? Was it the new department? Who was it? I think we probably could have done with that, and that's something for us to have a think about as we move into the future. In summary, and to wrap up and to move into the discussion from our grant holders, I think the HRB mobilised and was flexible. The research community mobilised. You mobilised, and you're still responding, which is just as wild because the information gaps and the evidence needs persist. The pandemic requires solidarity, collaboration, and coordination. I hope that the HRB won't be found wanting in that. The future is open. PPI and public engagement and involvement is more important than ever, and we need to figure out how to tackle misinformation. We will continue to prioritise flexibility for all grant holders and welcome and encourage HRB grant holders to avail of the HEA fund to the greatest extent. And I can't but conclude by saying that probably the biggest reflection for me as Director of Research, Strategy and Funding in the HRB at this moment in time is public investment in research and investment needs to be prioritised. COVID RNI, non-COVID RNI, we need to increase public investment. Murray showed yesterday that we're already lagging way behind, no matter what measure you do, in relation to funding for research in Ireland. So public investment in research and innovation and in health research needs to be prioritised. I look forward to the discussion later. Thank you.
Well, thank you very much, Teresa, for that. That was a great overview. And I know you're going to be coming back to the panel later or shortly. So again, a reminder to everybody to put your questions into the live Q&A if you have a particular question for Teresa or indeed for the HRB, just to put that into the Q&A. Okay, we're going to move on now. We're going to hear two presentations from, I suppose, the researcher perspective, generally on the subject of how you can adapt your research during the pandemic and some researcher solutions. And so first up, we're going to hear from Dr. Sarah Burke. Sarah is the Assistant Professor of Health Policy in the School of Medicine in Trinity. And Sarah's research interests are in health policy, health systems, inequalities in health, and access to healthcare, as well as the politics of health reform. So there's a lot going on there. And Sarah's going to be talking to us about shifting the focus from the regions to the COVID-19 health system response. Living the Life is the title of her talk. And it's about co-producing evidence to inform Sláinte Care's implementation. So I'll hand over now to Sarah.
Good morning, and thanks to Mairead and the team at the HRB for inviting me to present this morning. And for the next 10 minutes, I'm going to talk to you about how the research that I've been doing has changed significantly over the last year. Health system foundations for effective regional integrated care areas began its life in October 2019 as a HRB Applied Partnership Award. The partners were the HSE and the Sláinte Care Implementation Office in the Department of Health. And the aim of the research was to co-design and co-produce research that would feed into the design and the implementation of the new regions, which is a key element of Sláinte Care reform. The team originally brought together is made up of myself as the PI, Laura McGahey as Deputy Secretary General in the Department of Health and the lead knowledge user in the project, The 5 headshots on the left are of senior personnel in the Department of Health and the HSE, all of whom are co-applicants. Josep Figuera at the bottom, Director of the European Observatory on Health Systems and Policies, also co-applicant alongside Steve Thomas and Sarah Barry, my colleagues in the Centre for Health Policy. Also involved from the centre are Porrick Fleming and Bridget Johnson, who've been working on specific aspects of the project. And to the right are a range of the collaborators. And in particular, I mentioned Paul Kavanagh because he's a collaborator, but also a proportion of his time in kind is involved in this project. In terms of where foundations had got to by this time a year ago, we'd spent the first couple of months getting up and running with the ethics secured. We'd made good progress on a specific piece of work that's been led by Sarah Barry, which the Health Systems Unit in the Department of Health had asked us to do as part of Foundations, which was how can we learn from previous service reorganisations in Ireland so that we can do the regions better. And Sarah Barry led on this, doing international rapid review of the literature, but also primary research in terms of documentary analysis and interviews with 10 key informants. We'd begun rapid reviews on 2 other components, resource allocation based on population health profiling, and Paul Kavanagh and I had begun work scoping a rapid review in relation to data and what data would be most relevant to inform the work of the project. We were documenting the policy process, and this included participant observation within a new team formed between the Department of the HSE to roll out the regions, as well as ongoing dialogue and discussion with key partners. And all of this was what we were called building the life, the living implementation framework with evaluation, co-producing research and evidence and feeding that research in real time into the system with a view to informing implementation. And then there was COVID. And very early on in those days in March, Laura McGahey and I were talking to each other a lot on the phone. And what had happened was that pretty much everybody else who had been involved in the regions from the Department of Health, the HSE, were put onto the COVID response. So the regions, so the topic of research and the policy process, which I was researching and feeding into, was and has been for the last year put on ice. And we were also noticing that there was all these things happening in the system that seemed to be quite relevant to Sláinte care. So the universal nature of COVID-19 testing, diagnosis and treatment, the big push to keep people outside of hospital, universal access to GPs by telephone for COVID-related symptoms, the contracting of private hospitals for public patients for 3 months for surge capacity, increased mobilisation of health workers and hiring of additional staff, and also a whole range of activities in the area e-health, in particular e-prescribing, which went universal in the early days of the COVID-19 response. And we were discussing if and how foundations could harness some of those learnings to inform Sláinte Care's implementation. And simultaneously, us in the centre, we were asked to contribute to to report for Ireland, and we've reported weekly for Ireland to the COVID-19 Health System Response Monitor, and just saw an opportunity there to feed Ireland into this broader European and global project and to learn from what was happening globally and at a European level for Ireland. Obviously, the shift in focus of the research had to be negotiated. It was quite time consuming, both with dialogue with the Department of Health and the HSE, many of whom were much busier doing specific COVID related work, but we negotiated the shift with partners, and then the HSE agreed to that shift in focus on the basis that we published a protocol, which I was delighted to do, although proved extremely time consuming to do that too. And critically, while the area of research, the content of the research changed, the methods we were using of co-production, co-design, gathering data with the system, rapid reviews, feeding that into the system, maintained the same throughout. And so the new Foundations was about building this living implementation framework to learn from the COVID-19 response rather than to inform the regions. In terms of what made it possible to adapt the research, I think people were key. We've had a very good working relationship with partners, and in particular the lead knowledge user. The personnel were pertinent to both topics. So we were lucky that the group of people I had gathered together over 2 years ago when drafting the proposal for foundations were still very relevant in one way or other to the health system response to COVID. And the engagement and support of these people was absolutely key. And this was based on good, robust, supportive working relationships and a high level of trust. And I think that trust was key. As I said before, while the topic or the area of focus changed, the research design and methodology largely remained the same. And that was important in terms of our ethics, our contract, our budget. And in particular, I think the nature of the research, which is iterative, responsive, co-design, co-production, largely qualitative, although there are quantitative elements to it, I think that helped us shift so quickly. And there was a lot of hard work and patience and goodwill that got us there. In terms of progress that we've made to date, we've completed that reorganisation research that I referred to, and we've continued our work on the other rapid reviews, although some of those have changed to respond to the current situation. We've done this substantial piece of work with partners, scoping, documenting and assessing 62 of the COVID-19 health system responses. And ongoing work is with 17 clusters of these, and this month we are beginning to collect indicators on 10 of these initiatives and to do 3 in-depth case studies, the focus being on what are the sustainable and scalable elements of the COVID-19 health system response that can inform and contribute to Sláinte Care's implementation. We're continuing to document the policy process and engage in dialogue engagement with partners. And all of this is our life, our living implementation framework with evaluation. In terms of some reflections on changing the research focus, and the question that kept on resonating in my mind throughout the preparation for this session was it worth it? And these are my reflections rather than those of the team. And when I say team, I use the term loosely because in fact just myself and a postdoc are funded on this project, but it has had this very much collaborative partnership approach to it. And I think I feel quite strongly that it's been a privilege to be researching what we are researching at the moment, that what we are seeing alongside the grief and the loss and the sickness caused by COVID-19, there is also this extraordinary health policy and health system change never seen before in my lifetime or in my working life, and perhaps in the history of health systems. So to be part of the academic research that's trying to harness and capture that, I think is a real privilege. The work we've done to date has been credited by partners as influencing, just in the last 6 to 9 months, the Programme for Government, the Living with COVID plan, the HSE COVID Winter Plan, the yet to be published HSE National Service Plan, and Sláinte Care implementation in 2021 and beyond. I liked this quote from Robin Sharma, and we are in the messy bit, and not only that, but we're in the messy bit in the midst of a global pandemic. So I'm looking forward to living the life, to getting to the gorgeousness at the end. Although the hope of this project is that while the research ends in 2021, that many of the ways of working or the data gathering are continued by the project partners. Ultimately, Foundation seeks to use health systems and policy research to inform practically and academically the implementation of Sláinte Care in Ireland and health reform internationally. And I think if we manage to contribute to that in any small way, then absolutely changing the focus of the research has been worth it. And I look forward to our discussions on this matter.
Thanks very much indeed, Sarah. That's fantastic. We'll move on to our second, and again, just to remind you that there will be, if you want to ask Sarah a particular question, please just put it into the live Q&A. So we'll move on then to our second talk from the researcher perspective, and I'm very pleased to welcome Professor Fionnuala Brannock. Fionnuala is Associate Professor of Obstetrics and Gynecology at the RCSI. She's a graduate of Trinity, and she also trained in the US, and she has a master's in healthcare ethics and law. And Finuala's published widely on her research area, or area of interest is around diabetes in pregnancy, multiple gestation, obstetric ultrasound, and high risk pregnancy. And she's also currently leading the HRB funded mother and baby clinical trials network. So Finuala is going to talk to us about overcoming the challenges of running a randomized drug trial in pregnancy during the COVID pandemic. So over to you, Finuala.
Good morning, and many thanks for inviting me to share with you some of the insights and experiences we have had with running a randomized drug trial in pregnancy during the COVID-19 pandemic. I am principal investigator on the Ireland study, which is investigating the role of early low dose in aspirin in diabetes pregnancy. So this trial is being run through the HRB funded Mother and Baby Clinical Trials Network, and focuses on a very specific cohort of high risk pregnant women who have pre-existing type 1 and type 2 diabetes. So these are all of our partners participating in this study across 7 clinical and academic sites across the island of Ireland. Now, just by way of operational context, just very briefly to give a sense of the lead-in to 2020, we ran a pilot for this study between 2015 and 2016, and the DFRA grant was awarded for the definitive study in March of 2017. We ran into an issue with sponsorship, which was resolved ultimately with the Rotunda Hospital acting as sponsor for this trial and delegating sponsorship duties to RCSI. But all of that delayed us a little bit and required a lot of back and forth with State Claims Agency. Ultimately, the clinical trial agreements were signed at all 7 sites, but with a variable amount of time required for each site, and 8 months, in fact, in the case of Cork. So that ultimately, in December 2019, so just over a year ago, and 27 months after the grant agreement was signed with HRB, we recruited our first patient for this trial. Our target is 360 over a 36-month period. The 6th site, which is Cork, is a sizable site, just became active last month, and the final site, Limerick, is due to be green-lighted this week. So to date, we've recruited 56 patients over the first year of the study. And so we're certainly on our way, but it has been a long, hard road, and one that nonetheless is worthwhile. Now, COVID-19 could not have come, I suppose, at a worse time. Is 3 months into our initial recruitment, and what I would have to say is that just I work with some wonderful co-PIs across the country. We all have the same challenges effectively. We all have very full-on clinical commitments, and those have obviously been made more challenging this year, and that's a common theme across all hospitals. What was most striking to begin with is the overarching dominance of COVID-19 in the hospital setting. It effectively dominates almost all clinical decision making, and a lot of what happened at the beginning was very reactionary. So, for instance, an edict that no non-COVID research was to proceed, and that research staff were all to be seconded to contact tracing and other COVID-related duties in the hospital, and all of that really settled down. And certainly, I would say that from our own perspective, working in a standalone maternity hospital, it did become pretty evident reasonably early on that we in obstetrics do not have a starring role in this pandemic, and that's not intended to be self-deprecating in any way. You know, everything has been very challenging for us, really from an organizational perspective, caring for over 8,000 pregnant women in the interval since March 2020, and doing so safely in a way that protects staff, but also being very mindful of the very justified anxieties that we've been dealing with in our pregnant population. All of that has been really challenging, but it has been very reassuring for us to see that COVID-19 has not caused, thankfully, any undue morbidity in our population. The number of cases of COVID-19 that we've had have been small. They've all been community cases that have recovered. In that large patient population, we have actually only had 2 patients hospitalized with COVID, and that's intended to say hospitalized for COVID treatment, and not incidental COVID infection, hospitalized for the purposes of delivering a baby. And so we were able to, from a research perspective, we were able to step back and look at COVID-19 in context, and rather than taking the, you know, often sort of default position of, well, we cannot do anything non-COVID related, is to ask, well, what can we continue to do? And we've taken a very positive approach throughout. I think we don't really have a choice, and that has worked well for us. And it has been our experience with all of those with whom I collaborate and work across all of the network sites, is that we effectively have taken the same positive, proactive approach to proceeding with a trial that we have fought very hard for, and have felt very strongly about for a long period of time. So we have observed a disconnect somewhat between the universities and the hospitals, in that the universities have instructed, so all of our, certainly the majority of our research staff are university employees. The universities have instructed them to work from home, certainly during level 5, and you know, unless it's not possible to do so. And we have managed to get the majority of our research assistants back into the hospital with appropriate safety training and an appropriate risk assessment done and conducted by our sponsorship office. Our network colleagues in National Maternity put together a very nice online training module related to COVID-19 precautions and appropriate measures that can be adopted by research staff in attending clinics for the purposes of recruiting patients, and that's worked really well. Introductory telephone consultations have been really important to us, because one of the biggest constraints that we have is in not being able to conduct any face-to-face patient contact that lasts for more than 15 minutes. And that's very challenging in recruiting a patient properly to a clinical trial. And so we developed recruitment videos, videos accessible to patients via YouTube or to prospective trial recruits via YouTube. They get an introductory telephone consultation from either the sub-investigator or research assistant with us, who makes an introductory call to the patient, has a chat with them about what's involved in the trial. And all of that chatting can happen in advance of the patient's official screening visit at the hospital, you know. So that's been really important for us and has worked really well, and in a way that, you know, COVID or no COVID, we would continue with that practice, because it actually is from the patient's perspective, allows them to digest information much more readily, and they don't feel like they're being put on the spot. We would certainly continue with that strategy, even if COVID were to disappear tomorrow. One of the problems we've had are the patients that we are approaching have type 1 and type 2 diabetes. And this is arguably one of our highest risk obstetric populations. They don't tend to have 4 or 5 babies. They have 1 or 2. These pregnancies are all marathons, okay? And we certainly observed that those pregnancies kind of almost disappeared for the first few months of the pandemic, and we recognized pretty quickly that patients were deferring pregnancy because they perceived some uncertainty in relation to how COVID-19 might impact pregnancy ambitions or pregnancy health. And that was probably, you know, a lot of patients got spooked by seeing fertility clinics shutting down at the very beginning, under instruction from the fertility societies internationally, who said, well, you know, we don't know what effect COVID-19 has on pregnancy. Now that has all settled down. The data on pregnancy outcome is very reassuring, and so in recognition of the fact that COVID-19 is not going to disappear overnight, and that fertility prospects are finite for anybody, we're seeing, certainly in the latter half of 2020, then we saw a resurgence in these pregnancies just emerging. So we kind of felt that we had a population of potential recruits available to us in recent months that just didn't seem to be there at the beginning. So that really is just something that took time and that we couldn't do anything about. Really important from a risk minimization point of view is that is the avoidance of research-only hospital visits. And thankfully, our trial did not require for patients to attend the hospital for dedicated research visits, and those research assessments that were required, we were very careful to ensure that they didn't unduly prolong any patient consultation in a way that would expose staff or patient to infection risk. We did actually on 2 occasions rationalize down the assessments that needed to be done in a way that actually was very logical, and that obviously had to go back to H4PRA and ethics. And it was a case of just looking at, well, you know, do all of these blood pressure assessments actually need to be done? Well, under 20 weeks preeclampsia doesn't exist, and therefore it was overkill for us to have included those assessments in the first place. So just that exercise, I think, was that, you know, the discipline of repeatedly looking at our study assessments and ensuring that all of those that we had included in the schedule of assessments really needed to be done. That has been very worthwhile. Similarly, rationalizing pharmacy visits, so from 3 down to 1 dispensing visit, that has worked very well actually for us. And probably then the only final thing to say in relation to a challenge that we haven't yet resolved is monitoring. So really important for the integrity of this trial is that monitoring remains robust. And again, so the monitors are not HSE employees. We do have a memo of understanding that allows university employees to access patient records on site, but not remotely. And I think that's probably appropriate. I would not be comfortable with non-HSE employees accessing patient records remotely, although 3 of our 7 sites do have an electronic healthcare record. So and the Rotunda would be one such site. We have an office space, a single office space available for the monitor. But it hasn't been possible for us to, during level 5 restrictions, although that monitor is allowed to attend the university will not permit her to do so. So the monitoring that's happening just at the moment is happening virtually, but without the ability to do source data verification, and that has been deferred a little bit, and that's a bit of a challenge for us and something that we need to watch just very closely. Hopefully in the coming weeks we'll be able to revert back to allowing source data verification to happen on site with that monitor. So that is all I have for you. I'll finish with a photo of us being vaccinated, which might have been the most exciting time of the last few months. And we look forward to brighter months ahead. Thank you very much, and I'm happy to field any questions that you might have.
Thanks very much indeed, Fionnuala. That was great, and a great overview of the challenges of running a trial at the moment, and very encouraging the way you've actually adapted and been able to overcome many of them anyway. Okay, so what we're going to do now is we're going to move over to the panel part, and so people, please feel free to keep putting your questions in, and we have some good questions coming in already. So we're going to welcome back all our speakers to the panel, Martin, Teresa, Sarah, and Fionnuala, and I'm going to hand over to our moderator for this Q&A session, and very pleased to welcome Ian Brunswick. And Ian is the Head of Strategic Academic Engagement in the Science Gallery in Dublin. So Ian, I'm going to hand over to you.
Thank you very much, Mairead. It's a real pleasure to be here, and a real pleasure to hear about all the great work that you all are doing with the support of the HRB. As Mairead said, I'm from Science Gallery, so I'm not a health researcher myself. And as an outsider, it's really an inspiring topic for the day to think about the future and the future of research. And obviously, it's always good to think about the future, but I think this crisis has given us an opportunity to think about the future in new ways and with new perspectives. And I think the rapid adaptations, but also the ramifications this will have for the future, have really come to the fore at this conference. So we've got some questions that attest this, but I want to welcome back all our speakers. So Sarah, Fionnuala, Teresa, and Martin, and thank you guys for taking questions today. So if you do have questions, one thing I will say, if you're submitting them online, maybe just do note who you are or where you're from, and also keep your questions very short, and note who they're directed at. That makes it more useful. So I just want to kick off with one question that's been upvoted quite a few times, in particular because, Martin, you mentioned support amongst colleagues and kind of a cultural shift in research and practice, and how we have to be cognizant that people have very different scenarios during this pandemic. But I might actually direct this question at Teresa first, and maybe come to you, Martin, next. But somebody said it's been widely acknowledged that the pandemic, Attracted Lafferty said, it's been widely acknowledged that the pandemic has disproportionately affected women. And has the HRB considered how they might support female researchers whose work and career has been affected by the pandemic, particularly due to family and caregiving responsibilities over the last year? So Teresa, I might go to you and say, has this been on your minds, or are you thinking about this in the future, and more widely, kind of, because inclusiveness is one of the values in the HRB's strategic plan. So yeah.
Excellent question. Doesn't surprise me that it got asked and that it's getting upvoted. Yes, it has been on our minds. I think we're, like everybody else, we're aware. We've spoken about evidence and reports and surveys and so on that are coming out, and we are very much digesting all of that. We are having conversations with our fellow funders, not just nationally, and we're having conversations about this. We're looking at surveys that others are going to run with their grant holders and so on, and thinking about that from our perspective. But also because we have been, this is something that we've been looking at pre-COVID, and we're also interested in the kind of more acute and longer term inequities, if they're there, or supports that we can give or we need to consider. We are an active member of the 4Gen community of practice in Europe, and we're sharing a lot of ideas and details with that group. I would say in the immediate term, I've spoken about, our flexibility, which is across the board in relation to variations, amendments, no cost extensions, etc. And we are taking a look at that in terms of seeing the kind of gender proportions wrong. But we're across the board. We're open to doing that. I think we are thinking about, what this means at grant application stage down the line. I think funders can go so far in this. I think this is a conversation that funders and broader groups need to have with faculty and with the universities. So for those that are concerned about it impacting on career, particularly women at early career stage and so on, where it seems to, certainly in the literature so far, say that there is a disproportionate effect, we really need to have a joined up conversation on that rather than in any siloed way. We are, and you'll see in our strategy when it's launched on Thursday, working up an equality, diversity and inclusion policy more generally is something that was on our horizons and is very important for us in that strategy. So this fits very neatly into that. And I suppose the final thing I would say is we are thinking about how best to gather that information in terms of our own grant holder community. I think the HRB has a unique, fairly unique population in a sense. We know that the evidence is saying so far that health and medicine is probably again disproportionately affected compared with other funders. So I think there is something that we're thinking about from the HRB's own perspective in this space, but it very much sits within our broader equality, diversity and inclusion policy that we want to take forward.
Okay, thanks, Teresa. Sarah, I know you wanted to chime in there, so I'll go to you next.
Yeah, firstly, I think I'd love to just thank Martin for calling out those issues earlier about how people experience personally and professionally the pandemic differently. And I think it's very hard for everyone, but it's harder for some rather than others. As someone who is juggling both work and caring duties, I think that acknowledgement from senior people like Martin is really important, and also from the HRB and my place of work in Trinity. And while there is an acknowledgement, my day-to-day reality is there's just more work to do, plus homeschooling and caring on top of that. And I think an awful lot of people, and perhaps disproportionately women, are working early mornings and late nights to manage all that. And I don't know how sustainable that is. So while acknowledging it is important, it'd be great to see other tangible responses that support researchers in the months and the years ahead.
Thanks, Sarah. I think we've got quite a few questions, so we might jump to the next one and come back. This one is from Elin Mulrow, and it's directed at Martin in particular. Would love to hear Martin's thoughts on how we collaborate on an all-island basis in the context of COVID or any research disease area.
Yeah, well, you know what, I've been appearing probably rather too much on RTE and on Radio Ulster with Claire Byrne and Stephen Nolan and others, and I've consistently said that COVID, you know, we have to, I think on the island of Ireland, you have to look on it as a single epidemiological unit. And the paradox is that for decades we've done that for animal health, and yet we seem to be so reluctant to do it for human health. So I think, first of all, there has to be an acceptance of the need to do this. It just makes absolutely no sense not to. And yeah, I mean, I'm not on the island, so I'm probably not the best place to say how do you actually get the mechanics of doing that. But it does also need a degree of political leadership, which sadly, speaking about the bit of the island I'm from, has not really been so obvious. And of course, it's now caught up with all sorts of other issues as well. But, you know, then that comes to us as scientists to reach out, to reach across the border. Many of you are doing that already, and to really sort of up all of our efforts, and, you know, hope the HRB can do more. I'm sure that you are already, and it's just I'm not familiar with exactly what's happening. But I think it's absolutely essential. It just makes no sense otherwise.
Mm-hmm. I think this is another question, Sarah, that is very relevant to what you were just talking about. So what are your thoughts on this topic?
Not the research I was talking about, but I've been collaborating with another piece of research funded by the HRB under the COVID response, which Catherine Darker and Anne Nolan, the part of it I've been involved in, Anne Nolan, have been looking at COVID responses on the island of Ireland. And while I'd agree wholeheartedly with Martin that we are an epidemiological unit, what's very clear from the research, but also from anyone with an understanding of the political economy of Ireland, be it the island or north and south, is that that's much more difficult to operate in reality. One of the interesting findings from the research that Anne Nolan has been leading on, and there'll be a paper on this soon, hopefully, is that actually there's much more alignment north and south than is often perceived in the media or politically. And while there are huge political obstacles to that one epidemiological unit or an all-island policy, there is close alignment, and there's a lot of conversations happening behind the scenes between the Departments of Health and the CMOs, north and south. But certainly I think the more that researchers can contribute to that, but I don't think it's as simple as saying it's one epidemiological unit.
Okay, not a simple answer, but a hopeful one, certainly. We've got another question that is kind of directed to Martin in particular, again from James O'Mahony. He said, "I've enjoyed all the talks this morning, as I think we all have, but the media has a limited toleration for detail, and I think we had a few questions about policy. How do you address complex issues in relation to policy when the attention span of the public discourse is so limited?" Is it in fact so limited? I feel like it's we're getting a lot of public discourse about health in the media at the moment.
Yeah, I think we underestimate the public's willingness to look at complex issues. Part of it is, of course, the media want to talk about other things. So yesterday I got a call from Radio Ulster. Would I comment on the Taoiseach's decision to go to Washington for the St. Patrick's Day parade? And I have to say, as a Northern Protestant, I thought this is probably not where I want to be at all. I'm happy to talk about the variants of the virus, but that's for somebody else. And so I think we do need to try and come back to encouraging them to look in a little bit more depth. But it is really, really difficult because they only have you on for a few minutes at most. And it is always about the sort of, what some celebrity, or not always, but often about what some celebrity did or some other, what we would say is rather trivial point of detail. And I think we just need to keep working at pulling back and realizing we also need to use metaphors a lot more. I think Jonathan Van Tam over here has been very good at that, expressing some of the concepts. I mean, he uses football, which I have to say, as a rugby supporter, I'm not sure I fully understand. But he uses that, I think, very effectively. And I think we all need to be finding better ways of communicating that.
I think there was one question that came up about the role of chief scientific advisor. I think a lot of you have touched on the independent groups that have been kind of advising and commenting on policy. But how is the role of these scientific advisory bodies and individuals? Has that been successful in your mind largely? I might go to you, Teresa, actually, to chime in this. Do you feel like that's going smoothly and this is a framework for us going forward, or do you think this is a blip and we won't have this continued kind of public dialogue in the future?
It's a difficult one to answer, to be very honest, and that's not me sitting on a fence. I don't think the model that we have in Ireland in relation to our chief scientific officer, and this is my own personal view, is working. I mean, I've touched on earlier that we don't really have a convening or a kind of an independent convener to bring us together to talk about strategy, coordination, etc., etc. It was quite complicated, I think, and the COVID-19 put a spotlight on that, I think, in Ireland. So, I mean, clearly, I think it's probably less than ideal and it wouldn't happen, I don't think, in terms of if we were giving out grant funding or so on, we'd be lambasted in a sense for having head of a funding organisation, probably the largest funding organisation being the chief scientific advisor. So I think, and that's not a personal comment by any manner or means, but it is actually an issue that it's quite difficult to engage with. I think a second issue was that it was quite difficult anyway because of the complicated structures, the decision-making structures and so on, linked to our NEFID structures, where there were probably an order of about 12 different subgroups. Some had researchers on. Thankfully, many of our HRB-funded researchers in behavioural science and linked into the back of IMAG and so on were in there. But there were many others where there weren't. And so the input into the decision-making process, certainly within the Department of Health, was a small group that was advising to an advisory group, where you weren't connecting with workforce and behaviour and modelling, etc., etc. So it was quite complicated. I think it's fair to say it was very hard to see and to connect to the decision-making process, and largely the conversation of a small group on which the Chief Scientific Officer sat, as did the HRB, as did a representative from the universities and so on. It was largely around trying to coordinate what was already happening, and largely at the outset an information sharing group in terms of coordination, rather than, I suppose, what we would have discussed earlier, perhaps through Martin's talk, SAGE or independent SAGE or otherwise. So there wasn't that entity, that didn't happen at government level, and it didn't happen and connected out. So it was very complicated. It changed a lot. Our Chief Scientific Officer is now on NEFIT. I can't comment, have no detail in terms of the impact of that. But as from a funding agency, it's not that clear. And I suppose it's not just in COVID. It's probably the point I made earlier. Moving forward, I think it's something that we do need to address, how we quickly and agility galvanise and have a go-to place as government departments and funders across the board, tourism, EPA, all of those aspects, and come together and discuss something like the COVID-19 crisis, which in turn, to answer your question, makes it quite difficult then in terms of that public discourse and that engagement. So one thing begets the other. So unclear, I think, is probably the word I would use, and in that sense, not something to take forward. So we need a conversation about this, I think.
Okay, there's a good few more questions, but I just want to take a second in case Martin, Sarah, Fionnuala, in case any of you want to chime in on that point. Otherwise, I'll go to another question. Okay, this one's, oh yeah, go ahead, Sarah.
Just my experience, because of the nature of my Applied Partnership Awards, is probably operating with people in the system a level below Teresa. And my experience of the HSE and the Sláinte Care Implementation Office was, you know, this thirst for research to inform their decisions more than ever. You know, like they embarked on the grant with that intent, but it was escalated by COVID. And in a way, it was the point Martin made earlier. They wanted 100 questions answered yesterday, you know, and I'd be saying, okay, well, maybe we can answer 1 or 2 of them in 4 weeks' time or in 4 months' time, which obviously is never enough for policymakers. But I'd be more hopeful than Teresa that people in positions of decisions, be it in departments or in the health services management, realise how research can contribute in real time to the decisions that they're meant to have made yesterday.
I could just, I completely agree, Sarah. I suppose the question was, I was being asked in relation to probably that more macro level in terms of, you know, the Chief Scientific Officer or whatever machinery people have in countries. All of the things that I described earlier that our grant holders have been doing, that the HRB mobilised to, and certainly from my time in the department, was through those, I would call, downstream bilateral engagements with the decision makers on the ground, and that worked fantastically, and the hunger was there, and that is definitely in the bank for going forward. So in terms of understanding the importance, wanting it yesterday, and on speed, I couldn't agree with you more. I suppose because my final point was about funding and trying to get funding to do, even if you didn't have the time to do the 100 things, but trying to get funding for that. I do think there is something that we need to focus on there, but I couldn't agree with you more in terms of the hunger, the thirst, and the success of those interactions and those relationships. It was fantastic.
Okay, we've got another question from Avril Keenan, and this is for you, Fionnuala. Do you think your new patient recruitment practices, you know, involving phone calls, videos, etc., do you think these are more widely applicable in Irish clinical research looking to the future?
Oh, for sure. I mean, I think that we have been under you know, significant pressure to not extend face-to-face contact with patients beyond 15 minutes. And so conducting a clinical assessment, you know, a patient visit in conjunction with a recruitment to a clinical trial in under 15 minutes is completely unrealistic, and consent to participate
cannot be properly informed if it's done in a rushed manner. So we found now really important to emphasize that this isn't cold calling, so when the patient this particular cohort attends the hospital at a very, very early stage in pregnancy, in fact, before they have ultrasound confirmation of pregnancy. And so that first initial contact in person in the hospital will include the patient being told that there's an opportunity for her to be considered for participation for the trial, and for her to give permission for her contact details to be shared with the research team. So that makes it different from, I suppose, cold calling could be unwelcome from the patient's perspective, but we've had a really positive experience with those screen-in phone calls, and where an explanation is given in relation to the what the trial participation involves, and also they get the link to the YouTube video. We've had a really positive experience there, and so we would certainly continue with that format. We do still require wet signature for consent, but that's all obtainable once their recruitment visit is aligned with their next clinical attendance. So yeah, we'd apply that same model to any studies going forward.
Okay, great. And one more practical question, actually, from Andrew Murphy, and this is directed to Teresa, but I suppose this is really anybody. Feel free to chime in on this. They said in your presentation you mentioned public investment in RNI needs to be prioritized, and they said no dissenters here. How can we as a community work together to achieve this? So what can we do to make this happen? Oh no, Teresa, you're back.
I think continuing to do a lot of what has been demonstrated pre-COVID and during COVID in terms of engaging with the public in policy briefs, because obviously, a lot of change happened through influencing the decisions of government and politicians, particularly with our system here in Ireland. I think continuing to work with your funders like us in terms of keeping us abreast of outputs, developments, and so on. But I think, and again, I mean, I make reference to those, our grant holder community working very much with us on the, particularly the new intersectoral group that is going to be taking forward the next strategy for science, technology and innovation in Ireland. I call it the refresh of Innovation 2020. I think that group has already in its very first meeting acknowledged that it was difficult last time round, that we had a very ambitious plan, and rightly so, because we have lots to do, and we are lagging behind other countries in terms of our spend on all research and development. But last time round, the ambitious strategy was approved, but no additional funding forthcoming into the system from government. So the very first discussion, we've only met in one meeting, and I think certainly I was heartened by that challenge, but at least by acknowledging it, that actually that needs to change this time around. So all of the funders in all areas getting together need to make the case for that. But our grant holder community can really, really help us and the Department of Health make the case for health research and health and social care research. And I think we're in a very good position post-COVID, if that doesn't sound a bit perverse, for all of the issues that shone a light on, to show why health and social care research and behavioural research and implementation science and comparative health systems research and so on is more important than ever, to nest in and wrap around our Sláinte Care transformation plan for the system. So that's probably what I'd answer to that.
Okay, Martin, I know you wanted to chime in on this as well.
Yeah, I mean, this is something that we're talking a lot about. I'm I chair the Scientific Advisory Board. I'm a commissioner on the Monti Commission, which is on health and sustainable development in Europe. And it's almost all former politicians, central bank governors, people like that, with a handful of health professionals on it. And the sort of things that we're looking at and which are getting a lot of traction, because Sylvie Goulard from the Banque de France has been pushing this in particular, looking at the model they have among central banks of greening the financial system. Mark Carney's been talking a lot about this in his Reith lectures, and trying to find a model which will support health investment that links to that. Similarly, looking at the idea of something similar to the Financial Stability Board that was set up again by the central banks and the G20 after the global financial crisis. We've been looking at the ways in which national accounts might separate out consumption, investment from consumption, so that you don't lump them together and you see investment as investment, and therefore it becomes prioritized. Looking at the way in which we might try to get health and health research into the Article 4 consultations that the IMF have with governments, and then working with the credit rating agencies to add health and health research into their environmental, social and governance indicators. So there's a range of issues at a rather different level that we're actively looking at. Now, these will be coming out in a political statement from the Commission. I wait until you see them in print, but they should be coming out fairly soon. But we want a very open process with debate on these issues. And I think if we can manage to get support, and as I say, we are getting a lot of support, and particularly feeding into the G20 process, and in particular now that Mario Draghi is now the new Italian Prime Minister and will lead on this, I think that we have some support. People are really keen to do things after the pandemic. And I think for the message for us in public health or health research is that we really need to get out of our silos and have these discussions with senior politicians at head of government level and in central banks and elsewhere, because that's where the big decisions will be made.
So I might throw the last question to you as well, Martin, but to all of us really. This came in earlier, but if you had to choose one, and this is a good way to wrap it up, I think, if you had to choose one, what one learning from this pandemic should be at the forefront of our approach to future-proofing health research? So if you only got to pick one kind of learning, what would you go with? And I'd love to hear one from everybody to round this out. So Martin, to put you, Sarah, you want to jump in? Great, a volunteer.
For me, there's something about us as researchers having really good relationships with the health service users and planners and deliverers and health policymakers in advance of the crisis. And for me, that's what worked in my situation, was that we had those good relationships, and therefore we were able to respond agilely and meet their needs. But it's very hard to do that in a crisis, because all those people were suddenly at the front line of responding to the COVID crisis. So there wasn't that time. So it makes the case even more for that relationship building with the people and the partnership approach that has been supported by the HRB.
Okay, wonderful. Fionnuala.
Yeah, I totally agree with Sarah there. I think that for me, the most stark, I suppose, if we were to pick one, quality or characteristic, that was most important to us over the past few months, it has been solidarity with our team and enabling flexibility for, and I'm mindful of, the discussion we had about the challenges that people have, that, women have, that working parents have. Initially, it was remarkably unimaginative to think that that working from home was considered an accommodation, that this would answer the difficulties that working parents had, was that, well, now this group can work from home, and working from home is helpful to some, but certainly not to lots and lots of our team. And so individualizing the arrangements that we've had to have with our co-workers has been really important, and that has required a level of teamwork and solidarity that we never needed before, because we were just drifting along, everybody in their own sort of small bubble. And so not only that, but solidarity with our patients, I think, has been enormously important. And I think that our patient population really gets it and understands the enormous pressures that we've been under. And I've been blown away by the support and engagement that we've had with patients. We don't have a population of patients that declines and doesn't want to engage in research. That's really unusual. So the fact that our patient population has stood up and wanted to be counted, I think, has been really important to us. So any progress that we make going forward is going to be a true researcher, clinician, patient collaboration, and I think, enormous positivity has come out of our experience in the last few months. Everybody's a little bit jaded, but there's a smoldering positivity there all the time that I think is just a privilege to behold. Actually, it surprises me every day.
That's really heartening, Fionnuala, and that's a really hopeful kind of green shoots way to look at it. So thank you. Yeah. Teresa, did you want to chime in there?
Very briefly, I'd like to echo the point that Sarah made, both colleagues made, but particularly, I suppose I was going to answer areas where there was existing networks, groups of people working together, and things that could mobilize. We really had quite a quick and an excellent impact within this pandemic, and is continuing to do that. And relationships that were fostered, that really allowed, that's where there was really a tremendous impact and really applied and flexible thinking. And I know that a number of the people on the call had asked earlier about, would schemes like the Applied Partnership Awards and so on be part of our strategy? And it's an opportunity to go, absolutely yes, because that's where those relationships and the policymakers, the planners and the researchers get together. And just as importantly as the outputs of the research, get to know one another, get to trust one another and understand that landscape. And then the second point for me is kind of related to that. Certainly in my roles, both in the department and in the HRB, I was just blown away by the collaboration and the solidarity at an international level, if I can call it that, and particularly our EU colleagues. Just tremendous sharing, giving of time and working together. So yeah, they would be my two key points to pick up on this conversation.
Thanks. And final word, Martin, one pandemic learning for carrying us through to the future.
Yeah, throughout this pandemic, we've seen almost the entire gamut of cognitive biases played out. And I think as researchers, we need to understand much more about how when we say one thing, people hear something completely different. We started off with a playbook, which was in many countries pandemic influenza, and we just assumed that this was going to be the same. In East Asia, they had a playbook which started with SARS, and I think they understood much more about coronaviruses as a result. We've been doing a lot of learning, but we've taken a very long time to pick up on face coverings, on airborne transmission, on all sorts of other things that we should have known and which other people were saying. But this groupthink, this anchoring bias, all of the difficulties we have, and we've had a huge amount of, as you know, the Dunning-Kruger effect, which is where those people who know least are most confident about what they're saying. So I think there is a long, probably a PhD or several of them to be written on the cognitive biases that have been problematic. But I think as scientists, we actually need to understand what they are and recognize them and understand the ways of challenging them. But I totally agree with everything everybody else has said, and particularly that of having good relations with policymakers beforehand. And I think in the European Observatory, we do have that, including with some of your colleagues in the Department of Health in Dublin, who we do talk to very regularly. And it helps a lot because then you've got trusted relationships whenever you do have a crisis.
Well, thank you. As the person on the panel who knows the least about this, the Dunning-Kruger representative, thank you all very much for this really insightful discussion and for your presentations. It's been really wonderful. We've gone just a tiny bit over, so apologies to Mairead and the whole crew, but I want to thank each of you, Martin, Teresa, Fionnuala, and Sarah, so much. And we'll hand it back over to close us out to Mairead.
Thanks very much indeed, Ian. That was very well moderated and a fantastic session, actually, and really good questions. Thanks everybody who put questions in, and if we didn't get to it, sorry, but it was really a great span of questions, I think, and it shows the complexity of what everybody's dealing with. It would be a fool's errand to try and sum up the whole morning, but just to pick out some of the things, I suppose, just some of the key messages we were hearing about the impact of COVID on research and the really very profound impact from different angles. And Martin started off by reminding us in a very practical way of just the difficulties of doing research during a pandemic, the fact that a lot of field work is impossible, the fact you can't meet in person. He referred to the tyranny of Zoom. Oh God, we can all relate to that. But even things, the ethical challenges in terms of getting consent and so on. And, lessons there for all of us funders and ethics committees, the importance of just being flexible and understanding of these difficulties. I think we heard from different speakers and indeed from people in the audience about the way people are experiencing the pandemic differently. It's particularly hard, I think, for early stage researchers who may not have, may have very limited workspace, or indeed, people who are dealing with young children or indeed other caring responsibilities as well, and how hard it is to do that and combine that with doing your research. Came up again in the Q&A as well. And Teresa was talking about the need to have a joined up conversation with other people, the universities, research performers, and so on. And I suppose just the need generally to gather some information on this from our grant holder community so that we can respond appropriately. We heard of the importance, I think, just of just being encouraging and reaching out to other members of your teams. Fionnuala gave us some lovely practical examples of the difficulties of running a trial during COVID, but also some of the really practical ways that they've addressed those and the things they've been able to put in place, like the fact that, first of all, they had to bring people back into the hospital system who were working at home, because obviously they couldn't do some of their work from home, but also nice innovative things like using videos and YouTube to reach out to patients, and the experience they've had with that, the positive experience, and they may continue doing that. There was talk about how to disseminate your work, and a lot of people commenting on the increase in preprints and the different ways now that people are disseminating their work. We were reminded that the future is open. We talked about the importance of being joined up. Sarah was telling us in the context of North-South cooperation that there's a lot more than we've acknowledged, and she was also talking about the importance of trust. And Sarah was pointing out that even with all these problems, just being involved at a time of so much extraordinary change is actually a real privilege, and we think we can all say amen to that. And Sarah gave us that lovely quote about change being hard at first, messy in the middle, and gorgeous at the end. So I suppose maybe we'll just cling on to that for dear life and hope we get to the end. The whole question of infrastructure came up, and the importance of actually having infrastructure in place. I think Martin was mentioning, for example, the importance of being able to pre-approve protocols, and it came up again from the funders' perspective. I think where we have had the infrastructure in place, we were able to respond quickly and adapt. There's a lesson here for us and for policymakers and funders and the political system. We need to invest now to future-proof our research and our health system, so that we're in a better place or in a good place, when the next inevitable challenge comes along. And we heard as well about the importance of having good relations with the people who make decisions, so that when the crisis hits, you're not trying to sort of do it, in an emergency situation. And I think we talked about the need to increase investment in health research. The fact that we have to get out of our silos, I suppose, and just start engaging with people all around the political system and talking about the importance of that investment in health research. So I think overall, everybody, look, it's a cliche, it's an understatement to say this is a very, difficult situation for so many people. But on the other hand, we've also seen how people have mobilized, researchers have mobilized teams, funders, and just the real importance at such a time of being flexible and being understanding of people's particular problems, because of course, as people said, it's not affecting everybody. It's affecting everybody, but it's not affecting everybody in the same way. So we were reminded that showing solidarity, I think, as Manuela said, with each other, with patients, and hopefully we'll all come out of this stronger and wiser. So I think we've gone a little bit over time, but it was worth it. We're going to leave it at that. I just want to point out to you that all the presentations will be available on the conference platform later on today. I want to thank all of our speakers who took the time out. You're all so busy to prepare presentations, and you took the time then to stay on, to sit on the panels and to answer questions. Personally, I want to thank very much the communications team in the HRB who put a lot of this together and are behind all of this, and indeed our help with the technical support as well. Of course, I want to say congratulations again to Professor Jerry McElvaney on his HRB Impact Award. And finally, I want to thank all of you for joining us today and for being such active participants. You are fanatically busy, I am sure, but the fact that you took the time to join us was really, really wonderful, and we really value that and appreciate it. So a very big thank you to everybody, and from everyone here in the HRB, goodbye. Have a nice afternoon.